welcome. This is the first of three what we call intensive sessions for the Kidney Scholar Teams program. And our goal here is to really dive deeply into some of the what we call primary palliative care skills around communication, around alternative treatment options that might be useful for patients who are seriously ill. And these are the cases that we've discussed so far. Again, a shout out, I think, to Jillian and Hajung for helping us find these cases.
And one of the issues that we frequently run into is escalating or de-escalating care, particularly in the ICU. And that's obviously not patients with end-stage kidney disease. Frequently, it's patients with AKI, but that's a frequent issue that we face as well.
What we're doing today, motivational interviewing tools with specifically the skill building around open-ended questions. Next session, skill building is around naming emotion. And the third session, skill building, is around the skills of rolling with resistance and elevating ambivalence. And then we're going to look at a roadmap we've developed called Highway for advanced care planning and some tools in advanced care planning. Next slide. Okay, so we want to know what you're struggling with and what you're hoping for. And especially Jillian and Hajung, maybe what you hear from, the teams that you're working with and educating. What are they struggling with?
I think from the staff nursing perspective, since they encounter the patients initially, if there's an issue before they go to the social worker, how they should handle the issue. It's a very sensitive topic. A lot of them may feel uncomfortable addressing it right then and there. So we like to arm them with the skills on how to relate with these patients and then, pass it on to the social worker. Just their initial contact and how to deal with it and how to handle it.
Okay. Joe, what do you see your residents and fellows struggle with?
Well, it's actually initiating the conversation. Again, what we find or we have out in Queens, we're not so much dealing with the patient as much as we're dealing with the families and unrealistic expectations and goals that are not clear. And then the other real challenge is when there's disagreement among the family members.
We want to start with a clip that is, it's a real example, although I actually don't know, it came from James Tulsky, who's done a lot of work around communication, both in researching it, physician communication, and teaching. And so I don't know whether it's a student and simulated or patient or an actual patient. I don't actually know that, but it is a real clip of a real student. And it is, in our mind, an excruciatingly painful clip to listen to. So I give you that warning. It's very difficult to listen to, but we're going to start there and sort of unpack what about it seems to be so difficult.
Talked about was the sorts of things that that you'd like us to do while you were in the hospital, because we have a lot of things available to us in terms of if something happened to you, something severe happened to you health-wise. There are machines and things that we have that we can restart people's hearts after they've stopped. We can put tubes down their throats to help them breathe if they can't breathe on their own. And because of your condition, your prognosis or your chances of surviving for a long time are limited. To be honest, I think that someone's probably already talked to you about this. Even when you were at Kaiser, they probably mentioned how long you might have to live.
They didn't.
They didn't. Okay.
But I used to work at the hospital.
Right, so you know about cancers.
Yeah.
Okay, so you know that your survival for, more than a few years is kind of
slim.
right. Okay, so what we wanted to know was that some people feel that when they get to a point, where they don't want what we call heroic measures taken. They don't want someone.
I know.
Okay. Okay. So just let me tell you a few of the things in particular that we do, just so that you understand. We can put a breathing tube down you and have a ventilator. You don't want that. Okay. And the other thing we can do is we can do compressions like CPR, like they do out in the street when someone has a heart attack. We can do those sorts of things. There's a chance we can restart your heart, but even if we do restart your heart, that doesn't mean that you'll come out of it 100%, and you'll still have your cancer, so it's something to consider. And the other thing we can do is there are lots of medications we can use. If your heart stops, we can inject you with some medication. This sometimes helps, but not all the time.
Yeah.
And we have an intensive care unit, which we can take you to if we needed to. And I wanted to get your feeling on that, because a lot of people feel that they want, that their idea of dignity, if they are to die, their idea would be to avoid things like that and just die peacefully.
Yeah, that's my idea too.
Okay, all right then. So actually what I'm going to do is, I'll make a note of this on the chart, and Dr. Brown, because he is the senior person here, will come by tomorrow morning and talk to you and just go over that with you one more time. But I think it's important to do, and if you do come back to the hospital, or if you go to another hospital, when you go to the hospital, you should probably let them know that those are your wishes, because with your condition, your lungs don't work very well, and it's easy for you to have so much trouble breathing that they would want to put you on a breathing machine. So if those are your wishes, and I think that it would probably be helpful for you to make a note of that to the physicians when you come in.
Yeah, that's what I told them this morning.
Okay, good. I'm glad you did. So we got that all straightened out.
Because
we'll make sure nothing like that happens.
I don't want my family going through that agony.
Right. No, I understand. That's very thoughtful.
I'm saying maybe that's what she want, or maybe she don't want that.
Right, sure.
But I'll speak for myself while I can.
Right. Okay. Right. That's true. And another thing that you may want, because you may want to tell someone in your family how you feel, because a lot of times what'll happen is they'll go to a family member.
They know already.
Good. Okay, that's good. Right.
I've made my will. Everything is it's taken care of.
Okay.
If I go tonight, all they have to do is go to the papers.
Okay.
And my cousin has the papers.
Okay, great.
I don't want to be put on no life support machine.
Okay.
And I don't want them arguing over nothing.
Okay.
All right, so what do you think? And Peyton, why don't you take away the slides so we can see each other? Any reactions, thoughts?
I thought his language was a little bit rough. I thought could have been improved. I thought that he probably could have started with sort of asking rather than telling, and getting an understanding of what her background was and what she understood of end-of-life care. So those were the couple of things that kind of stood out to me.
What else?
I thought he spoke too fast. It sounds like very nervous, and he just wanna get it done. He just wanna give all this information, and I feel like she tried to talk a little bit more about her emotions or her situation, but he wouldn't listen. That's how I feel.
Yeah. Jillian, anything to add?
Oh, sorry. In addition to everything Hajang and Dr. Silverswine have added, I do agree he seemed rushed, because I've experienced that personally myself when my mother was in the ICU, and it was a rush decision. Luckily, I had the background, so I knew what it all was about. But if I had a family member having to listen to them, I can't imagine what they would have said, because it's felt impersonable. I didn't see any empathy there. It was just, they were going through the motion of telling them, okay, A, B, C, D, and E. And, you know, I think that's what I got from that short interview.
Mhm, mhm. I'll tell you, every time I hear it, my heart goes out to that poor resident, probably, because he said, you know, the senior person's coming by. It's like that poor guy was just petrified, right? Terrified.
And the patient was probably even more
And
terrified.
so that wasn't helping the patient. That's right.
Right, right.
And
And
yeah.
and another thing is he said that his supervisor or whomever will come back and have the exact same discussion the next day. Don't put that lady through that again.
Yeah. 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 Well, so was there anything that went well in it? Can you give this poor, if you were supervising this poor resident, could you give him any good feedback?
No, I think he went in there non-emotionally. And I think that he at least managed through his anxiety to hear what the patient was saying to him.
Okay, great. Great. Liz, anything you want to add?
You know, I mean, I agree with all of you. And I think really what you're talking about is some of the skills that we're going to be building on today. I love what you said about you need to first get some background, right? And so, you know, a foundational skill of motivational interviewing that we're going to talk about is how important it is to elicit first, right? There's nothing worse than like actually knowing all the answers inside of you and then having someone kind of come in and like tell you everything that you already know. So like that process of eliciting, so we don't have to like walk people through painful territory if they've already done that, right? So I love that. And then, right, this acknowledgement that Hajung and Jillian made about how, you know, he was just so nervous that he wanted to get it done. And I think that's an important thing to pay attention to because, you know, compared to where we were 100 years ago, we do have a lot less exposure to death. And it is hard to deal with death or impending death. And so, you know, being here today, working on those skills help us sort of demystify it so we can show up for people in a way that they need us to. And something you all said earlier about another case, I think made me also sort of reflect on that, like what a gift it is when someone actually can share that information with us. And so, you know, how do we make sure that we kind of regulate our own self and build skills in that is so important. So yeah, I think that that's part of what was happening with this resident too. That motivational interviewing is grounded in this trans-theoretical model called stages of change, which you all might be familiar with. So motivational interviewing and stages of change theory really kind of come from work that was actually done in the substance use community. And recognizing that if we want to change a person's behavior, there are certain qualities that need to exist. And so it's been extended now to all types of behavior change. So motivational interviewing has been used to help people go get mammograms, to help people adhere to diet, even in the dialysis unit in terms of adherence as well. So we've used it across the board. But the stages of change theory really says that in order to change behavior, we go through these steps that are right here on the left. Pre-contemplation, contemplation, preparation, action, and maintenance. And actually, it's sort of like a circle. So it's just like, I like to use the analogy of smoking. So most people that smoke aren't going around on Friday saying, I love smoking. It's the best coping skill I ever had. I'm never giving it up. And then wake up Saturday morning and say, I'm throwing all this away. It's horrible. I'm done. Right. That there's a process in between that, in which they begin to think about it and they contemplate it. And so this is the process that pre-contemplation is like, I heard something on the radio that this was a bad idea, but I'm not even considering that. Like, whatever, life is too hard. I'm not going there. Contemplation is, I heard that this was a bad idea, and I don't know, maybe my lungs hurt a little bit. Preparation is like, okay, I know that smoking is affecting my lungs, and I've got to get a plan together, and I'm going to throw away all my ashtrays on Thursday, and I'm going to give all my cigarettes to my brother and move on. That's preparation. Action is the phase in which we actually do the thing. And then maintenance is, what are the things that we're doing to kind of keep us in that behavior change? And we can apply that to things like advanced directives, making decisions to choose conservative dialysis, et cetera, right? So we can think about how I might be over here like, oh yeah, I've heard that people talk about their future healthcare plans, and forget that. That's going to be too anxiety provoking for me. Or it might be, I've heard that people think that there's some options there, and maybe I want to talk to my doctor about that. Maybe I want to talk to my nurse about that. Maybe I want to talk to my family. Preparation is like, I think I'm ready to have this discussion. Action is I'm having the discussion. And maintenance is I am continuing to have that discussion. And the thing about stages of changes, we also understand that people kind of go backwards, right? And that a lot of times people sort of move forward in the process, and then something happens and they go back. But that every time they sort of relapse or go back, they come forward the next time better prepared than the time before. So, patients might toy with this idea and then have a scare and retreat, and then come back. Next slide. What about your patients? Where do you feel like they are in this process?
I think the newer patients are in the pre-contemplative state. I've heard a little about it. The social worker told me about it, but it's not for me right now. They're trying to digest the fact that, their life has changed and they need dialysis.
Yes.
Once they've absorbed, what the conversation that the social worker has had with them, they may ask to know more.
Yes.
The ones that have been in and out of the hospital, that has been in the ICU and come, and are back, they may be in the state of preparation.
Mm-hmm.
So I think, our patients have a plethora of stages that they're in. And
Yes.
it depends on their comorbidities, their experience in dialysis thus far, how many times they've been in and out of the hospital, how serious was the illnesses. So I think we will see that, it's spread out.
Yes. Yes. So, I think that's a really important thing that you just said, Jillian, because there can't be a cookbook approach to this, right? Because people are just in really different places. And I think that is a core tenet of motivational interviewing, which is like rule number 1, you start where they are, right? And so I don't know how many of you all have teenagers in your life. I do. And so I always think in those terms, but like one of the things I observe with teenagers is if I want them to say, go to bed at a decent hour. And if I say, and they're like, I want to stay up till 4 a.m. And I say, you need to go to bed at 10 o'clock, they move this way. Right. Then it just escalates. It gets worse. Right. no, you need to go to bed at 10 o'clock because, healthy brains are important. And then they go this way. And and then we're just like escalating, right? So from a stages of pain, change, motivational stages of pain to stages of change, motivational interviewing approach, we want to approach people where they are. So it would be appropriate for me to come in and say, go to bed at 10 o'clock. If somebody was like, I am ready to feel better. This has been awful. I'm so sleep deprived, right? That is a preparation stage intervention. But a pre-contemplative stage, if somebody's not ready for that information, then it's time to do exactly what you all just talked about and roll up our sleeves and be like, hey, what's going on? And so, we want to start where people are, understanding that the harder we push for someone who's in pre-contemplative phase, the further away we actually get them from what we want. Next slide. These are the primary skills that we are going to be talking about when it comes to motivational interviewing. Or is grounded in this idea that we start the conversation with broad, open-ended questions that give us a lot of information. So if we go back to that audio clip that Dale played, that we might go into the conversation instead of saying, have you thought about a DNR? Or I want to tell you about a DNR, or I want to tell you about options, saying, hey, I was wondering if you could tell me a little bit about what you're thinking about your future healthcare. That we're just assessing and gathering information and opening the door. And so the idea is that broad, open-ended questions give us a lot of information that we need. And it keeps us from feeling like we're on the stand, and that we don't want people to feel that way. So that we're going through the check boxes of questions. The second skill that we're going to talk a lot about is listening and empathy, which you all again observed with the case we just listened to. One of the things that we now know that I think is somewhat counterintuitive to how we all seem to learn is that actually when we listen and reflect and are empathetic, we get more information from people than if we ask them questions. Why might that be true? Why might it be true that listening, reflecting, and empathy gives us more information than asking questions, you think?
It gives people the opportunity to express their feelings openly and their thoughts and their knowledge. So I think that what you're suggesting is that you always want to give people opportunity to speak their minds rather than to suggest something to them.
Yes. Yeah. So it gives people an opportunity to, sometimes people just need to process it out, right? We just got to talk it out and figure it out ourselves. And we're giving them a safe space for that. Jillian, were you going to say something to us? I saw your mic go off.
No, I'm agreeing with.
Yeah. So when we listen and provide empathy, we're demonstrating to our patients that we get it and that we can tolerate it. So we go back to the other case where you all noted that the doctor was anxious, right? He was communicating, I'm uncomfortable with this, which kind of shuts us down. But when we listen and give empathy, it helps people feel like, okay, they can handle this and I can go deeper, right? So it provides some context in that way. And it builds relationship, right? We don't build relationship with a person by asking them questions. We build relationship by being present with what they're sharing with us. So we'll talk some more about that shortly. And then the other skill is information giving. And of course, in your job, information giving is really important, but it should not be in an end-of-life conversation or conservative care conversation, the entire context. And so from a motivational interviewing perspective, we want to hold out on giving people information until we've assessed through asking questions and we've offered support through listening and empathy. So again, kind of going back to what we talked about a little while ago, we don't want to tell people what they already know. So if we assess it well and they already have the answer, it's no reason that we need to like reiterate that one more time, especially for something that's really sensitive and difficult. The other piece of information giving that we're going to talk about is that it's important. There are a couple of important things. One, that we ask permission, because when we're using difficult content, people often feel like they don't have any control, right? And that's scary. Like you're dumping this conversation on me and I feel like I don't have any options. And that's frightening. And that now my emotion is come into the play and I'm not going to be able to really respond like conscientiously because I'm responding with emotion. So one way we work through that is we give people the option. So, if we go back to the conversation that we just heard, it would be like this. I'm hearing you say that you really want to make sure that you don't get resuscitated. Would it be okay with you if I share a little bit about what I know about resuscitation or what I've learned about resuscitation? So it feels like the power dynamic shifts and we're really, again, partnering side by side with them. The other thing about information giving, I am not practicing really well right this second, but that is that we want to give it to people in chunks. So it's overwhelming, especially if it's emotional. People can't take in, 5 minutes of lots of information. So when we give information, it's like we give a little bit of information and then we check in. And then we give a little bit of information. What do you think? How does that sound to you? How are you going to use this information? So we're going to be careful about how we give information.
And Liz, I just want to reiterate that to be prepared as a clinician or a provider, if the patient says they don't want to continue on the conversation, because that happens more times than not. And sometimes I feel like people aren't ready for that response from the patient. They'll ask the question, but they're not ready for that reply. And so then they're taken aback that, oh, now what do I do with the conversation because the patient doesn't want to continue on. So something to also consider and be respectful. If they say no, then you ask for a time when you can return and continue that discussion. And sometimes they'll say the next day, sometimes they'll say, give me an hour, I want to eat my lunch, whatever it is. So I just wanted to reiterate that because I've seen people been taken aback with that response from patients.
Yes, excellent point. And I mean, sometimes too, I think reflecting on that with them, because we show people we care through reflection and empathy. And so like, right, I can see you're so busy right now. You have so much going on. When would be a good time? Or, yeah, this is really difficult content for a lot of people. It's a whole lot to have right now. When can be a good time for us to check back in? So even making an empathetic statement in that moment to let them know that you care about them is probably going to move you further in the future because they're going to be like, oh, they get me. Then the last two skills are somewhat similar. And so the first one is resist the writing reflex, which actually Christy just kind of went into. And that is all of us in helping professions, I think, have this, and that is that we would like to fix people, right? I know what is best for you. I'm going to tell you what to do and you do it. And then the problem is solved, right? And so we have this urge to right things, to make things right. And so just like Christy was saying, if they're like, no, I don't want to hear this, and it'd be like, well, it is really important for you to hear this conversation right now because, if you don't do this, then your family's not going to know what you want. That would be like leaning into your writing, you're fixing, you're not honoring, right? So you're trying to make it better by like selling, right? That's what resist the writing reflex is like, I'm trying to sell my perspective on you. And from a motivational interviewing standpoint, we're going to say, stop selling, right? And hold space with reflection and empathy. And then the last piece of that is roll with resistance, which is also, I think, what Christy was talking about. If people say no, then like, okay, we're going to go back to stages of change model. They're in a pre-contemplative stage. They're not ready for this yet. I'm going to check back in with another broad overarching question another time. But also recognizing that resistance is part of the work. Resistance is part of being human. And if you encounter people who aren't resistant somewhere along the way, it's probably rare. So expecting that resistance to come and honoring that, because in the end, resistance is a person's defense mechanism. It is a way to protect themselves from something that's really, really painful. And if we strip that away from them too fast, then we're going to be dealing with a person that has a lot of emotion. And so again, that listening and empathy sort of helps decrease the defensiveness so that people feel ready. Okay. And then the last thing, always listening out for people's unique motivation. So the truth is, when it comes to something like conservative management of dialysis or advanced directives, all of us are motivated by different things. So my personal motivation for doing an advanced directive was, I worked in a hospice at 24 years old, and I saw a lot of people like in the hospital before hospice really, really suffer with pain. And I was really super scared of being in that kind of pain. So I got an advanced directive done in my 20s because I was so afraid of pain. But Dale, I don't know why Dale did her advanced directive, but she might be like, I really don't want to burden my children with making decisions. It's really important to me that they know what I want. And so her motivation for doing it is different. The bottom line is, it's important for us to listen out for what people's motivation is, and then use that in the work that we're doing, communicating with them. Okay, next slide. So we are going to do a role play that always makes my heart rate go about 60 points up, because Dale is going to be the patient. And but here's what we want you to do. So you need a pen and a piece of paper. Hopefully you have that close by, or you can use notes on your phone. But we're going to do a role play, and I want you to do just like hashtag marks of how many open-ended questions I made, how many close-ended questions I made, how many times I was listening or reflecting versus being empathetic. How many times did I give permission? Did I give information with permission? How many times did I give information without permission? And just listen out for me being flexible, resisting the writing reflex, or rolling with resistance. Now, I'm going to make a confession. I always try to do good on these things, but it is a lot of pressure when it's being recorded and people are watching you. And so I probably will mess up, which is good. It'll give us some fodder to talk about. But really, again, what we want to do is sort of play with this and then unpack it and talk about what could I have done differently in this role play?
And I think to simplify it, we want to concentrate on the open-ended and closed-ended questions, like really listen to those questions. So close-ended is something that can be answered yes or no, like, or this or that. Open-ended, so a closed-ended question would be, do you have an advanced directive? Have you talked to your doctor about an advanced directive? Open-ended would be, what kinds of conversations have you had with your family or your doctors about your future healthcare, right? So open-ended, the person can't just say yes or no. So concentrate on that, I think, and then the listening, reflective statements, and the rest of it, maybe we'll leave. If you see them, that's fine. So this says 6 months on dialysis. I think Jillian, you were talking about how people really move through. So we're going to consider this as somebody who's kind of adjusted to dialysis. So she's over the first shock of I'm needing dialysis, and things are going relatively well on dialysis. I'm married, and this can't truly be the first meeting with the social worker. Well, maybe it's a new social worker. Maybe.
Well, I was just thinking, I was going to say, in real life, I would never start with this conversation. I wouldn't advise that on like first 5 minutes.
Right.
And we're not going to be giving you a 30-minute role play. So we could say that maybe the relationship is newer. But yeah, maybe it might be.
But we've never talked about advanced care planning before. How about we'll say that this is the first time the social worker, I haven't brought it up. The first time the social worker is raising it to me.
Yeah.
And
okay.
And in those stages of change, I'm a little scared and resistant. Okay. So that's right. But I'll try. But we made this mistake before. I played, and we had somebody else play a patient who was, extremely resistant. So I'm intentionally going to be thinking I'm in the contemplative stage. I'm willing to hear something. Okay. There are people who aren't willing, and then we have to go with Christy's, you have to acknowledge that and not push them. But here I am a little willing.
Okay. You ready? Okay. Good morning, Dale. Good to see you.
Hey, Liz. Hi. Nice to see you come on the floor. Are we in the floor or in your office? You asked me to come in your office, so
yeah.
Good.
Oh, I'm so glad you're able to make it work. I love to be able to see people one-on-one without machines beeping and all that.
Really, those beeps. Oh my God. Sometimes that really, that's a lot of beeping.
Yeah. Really, Dale, I just wanted to check in with you. It looks like, you've been here for about 6 months, and I was just wondering, like, how's it going for you? What's it been like? How you doing with dialysis at this point?
It's a little better now. I'm kind of getting into the rhythm. I'm not so scared of it every time, and the cramps I was having are a lot better, and I know some of the staff now. So it was pretty scary at the beginning.
Yeah. In the beginning, a lot of times I hear patients say that, this is a whole new lifestyle for me, and all of the newness can create some anxiety, but it sounds like it's gotten a little more predictable and you've gotten to meet some people.
Yeah, I feel like it, and my doctor says it's going well.
That's great. So if you've gotten some good feedback from the physician, which has been reassuring for you.
Yeah.
Anything on your mind right now, Dale, just in terms of like that's worrying you or bothering you about your healthcare or about the future?
I kind of worry if my husband's going to be able to keep up with dragging me to this 3 times a week. It's pretty hard on him.
So in addition to dealing with your coming to dialysis, it sounds like you're worrying a lot about
his health's not so great either.
He's got some challenges going on too.
Yeah. So between the two of us, with my energy, even though the dialysis is going well, my energy is just not what it was. It's just not what it was. And his, he's tired too.
So both of you are feeling really tired, which kind of makes you sit back and wonder, like, what's it going to be like? Have you had a chance to talk to him about that at all?
We both kind of just, we just try to keep encouraging each other. Team. We're a team. We're going to get through it.
Yeah, you've been married for 50 years. You care about each other and you want to be positive in your interactions. Yeah.
I don't want him worrying more than he already does.
So yeah, it's important for you that he is not going to be worried about you and feels positive and supportive.
Yeah, he does worry a lot. He does worry a lot, but we don't really want to go there and talk about it.
So on one hand, you want to be really supportive of him and be positive, but on the other hand, it sounds like both of you are really worrying a lot about what the future
Well,
looks
I'm
like.
just, like, what if I have to go back to the hospital? What if he goes to the hospital? Our kids don't live near us. I don't really know what we're going to do.
Mhm.
And I've heard that, on dialysis, you can get an infection. You can, be traipsing off to the hospital. I had a friend who, I don't know, she was in the hospital, seemed like she was going back and forth.
Mhm.
We joked they should have opened a suite there with her name on it. She was there so much. And I just don't know. I've been lucky so far, but I don't know how we're going to deal with that.
Yeah. Yeah, like thinking about watching your friends go through something will make you can be scary, and you wonder to yourself, like, is that going to happen to me? And what am I going to do if that's the case?
Right. Yeah, she had her 4 kids all lived in the area, and they all kind of came around, and
Mhm.
I don't know what we'll do. I don't know how my husband would cope.
Mhm. Yeah, it sounds like you care an awful lot about him and want to protect him.
Mhm.
You know, Dale, you're not the first person that has told me that they worry about these type of things. And just to normalize that a little bit, I think anytime we see other people suffering, we wonder that about ourselves. Um, I'm curious, have you talked to your doctor at all about these concerns?
No, we've just been focusing on sort of that the treatments are going well, and we really no.
Yeah,
He's so busy.
yeah, yeah. So yeah, you've been focusing on what's really important the first 6 months, which is making sure your treatments are going well. But one of the things that I'm sort of thinking about is how here in our facility, how important it is that we don't just treat the kidney disease, but we're treating all of you. And I'm hearing that you're feeling a little bit anxious and worried about the future. And I'm just thinking to myself, like, I wonder if it would be helpful for us to sort of tease that out a little bit and think about maybe what some of your options would be, and to have a conversation about what are the things that you would like in the event that your health changes some point. And I'm curious your thoughts on that.
Yeah, I mean, we've been kind of not wanting to talk about it, but I think, everybody leaves this place eventually. So maybe it's time.
Mm.
I see. Can I role play break?
Yeah,
I just see on
come
the
out.
slide. I see on the slide I was supposed to be like, I'm not going to talk about dying.
That's all right.
So back to the role play. Are you telling me that it's going to get worse? Am I dying?
First of all, I hear you on your fears of like, oh my gosh, is this woman coming in here and talking to me about something I don't know? And I just want to clarify, this is something I want to check in with every single person that I see. So it's just really important for me to make sure that people's physical needs are taken care of and their emotional needs are taken care of. That it's not an assessment of how I think you're doing at this point. But it sounds like that would be pretty upsetting to you if I walked in here and started having this conversation, because I did think you were dying.
Yep, because my doctor says I'm doing great, and I'm planning on seeing my grandkids in a few months.
Yeah. So that would be a tough conversation to have, in light of the fact it sounds like it's really important for you to spend time with the grandkids coming up.
So I think I'm going to call it, I think, in terms of time. And let's just can we ask Liz to debrief it first, how that was for you? Well, first, let's ask you guys, did I do an okay job? Could you see me as a real patient?
Yes, definitely.
I thought you were very good, Dale. I thought you were more knowledgeable than most of the patients, you know, are.
Yeah.
But I thought you were believable.
Okay. All right. So you could believe it. You weren't going like, this isn't happening. All right. So Liz, how was that? What did your Garmin say? How bad was your heart?
Yeah. I'm looking at it. What is my stress level? Oh, maybe I can't tell it right now. I've done this before. I just got my new Garmin watch when Dale and I did this like back in the spring, and it went off and it told me to relax. I was too stressed out. So I've been doing this enough now. I think that I'm getting used to it, but I think I probably turned another shade of red. But so, you know, obviously every conversation is different because every patient shows up differently. But what I really tried to do there, because she was still new to me and we decided on the fly that I called her into the office, that I didn't want to just come in straight for the jugular. And so I was really just trying to feel out, like with broad questions, like what is worrying you about the future, which is actually a question I learned from Woody Moss. That I use even in my own clinical practice all the time, to really get at the heart of what is bothering them. Because oftentimes I find when we do ask that, people are able to go to, this is what I don't want to happen. And then we can kind of work backwards from that. So that is what I tried to do there. When you timed out the thing and came back with, are you going to tell me that I'm going to start dying? Then I thought to myself, dang, I should have said that on the front end. Like, this is a conversation I have with everybody. But I also wanted it to feel natural too. The one thing that I did there is I did respond and answer the question to, you know, de-escalate that worry that I thought she was dying. But I also just wanted to respond to the emotion, right? So clearly that brought up fear for Dale, and I wanted to name it. Like that would be really scary for you if I brought that up. Again, just to show that I understand, but also open that door, you know, flash the light on that I know this is a difficult conversation. And then of course, Dale went into her grandchildren, which would be part of what I would put in my back pocket, as that's her motivation to do an advanced directive, is that she cares about quality of life. She cares about seeing her family. How do we, you know, how does that fit into doing an advanced directive?
So we gave you guys a task. So I'm wondering what your counts, what did you see as you were keeping track of counts in terms of open-ended, close-ended, listening?
I didn't hear any closed-ended questions.
Okay. Anybody?
I heard a lot of open-ended question, a lot of reflective listening. I thought I heard one closed-ended, which was, have you had a chance to talk to your husband about this?
Right.
That's the only one really I picked up on. The empathy, I saw some of that. I saw some, one informing with permission. But again, I did hear a lot of reflective listening where you repeated back what she said.
And that's so different than the kind of assessment skills that we train nurses and physicians to have, right? Which are really, you know, moving through, gathering a lot of information in a organized way.
Yes, no answers.
So, you know, it's not a surprise that this might feel different to clinicians to do a conversation this way. Other reactions that you had to it?
No, like I said, like the direction the dialogue was going, the patient nothing escalated as far as emotionally. I really thought it went well.
Christy, any observations? You do a lot of these.
I think it seemed like a pretty collaborative meeting, I guess, or discussion. And I don't think that, I think Liz's ability to keep the questions open-ended and then also kind of rephrasing the emotion she was hearing you express, I think is super important too, making sure that she's hearing and understanding and providing the empathy for the fear and the anxiety and all of that that's happening and the concern over your spouse and future and all of that. So I thought it went very well.
And there was a part of me that was going like, okay, get to the meat. Come on. Are you going to push this person more? Right. And I wonder, Liz, whether you were thinking about that also, like, do we have to move, do I need to move this or were you feeling like, that'll be for the next time?
Yeah. I mean, I was thinking about that for the purpose of what we just did, but if it were real life, I don't think I would be thinking that. I would be trusting the conversation. But I am a clinical social worker, so I'm trained differently, right? But there are times that I am like, come on, let's get to it. In this particular case, I think you were giving enough that I was confident that we were, progressing some.
And one of the things that we are getting more confident about in the setting of dialysis center staff is reassuring people that this will organically evolve. It takes multiple conversations, and it's okay for it to take multiple conversations. And especially in the dialysis center, this is one of the luxuries that you have, is you see people a lot, so making good use of that strength and letting this play out and not feeling like to rush or push people is great. Okay, so welcome back. So to reinforce the point that this is the whole advanced care planning process is quite the journey. We, in another project, had developed this, what we call a roadmap that has these points along the way. And really where Liz and I were role playing was this welcoming beginning, establishing a relationship, kind of figuring out. She found out that really I hadn't talked with my husband much, quite different from the example we heard at the beginning of someone who said, my forms are all there. I've talked with my family. They know what I want, right? So she's assessing where I was. And then next she would move into the next opportunity. She'd be continuing to explore on finding out what my values were. So she already had the hint. I was concerned and worried about going to the hospital, but she doesn't know really, am I okay with going to the hospital, or do I have places when I would say, no, don't do that? So that's still in process. As someone is more ready to engage, then we want them to tell us who their healthcare agent is. And then we move into, okay, when someone's ready, now here are the forms that are going to help us put in place what you want. And one of the points we've made in other places is the forms are really there for the convenience of the healthcare system, right? A lot of people say, my family knows what I want. And from a family standpoint, that's great. But from a healthcare system standpoint, we need to know who to talk to and what the parameters are. And so we've developed these forms. Next slide, Peyton. When we developed Highway, our patients said, it's not really this linear go from stage to stage. So again, just like we were saying, when someone's moving through the stages of change, it's really a circling back. Even as Jeff said, he has forms completed, but his circumstances and his family has changed. It's time for him to go back. So again, being flexible to being where the patient is and kind of circling back at times. Peyton, 2 slides back, I want to talk about the difference or how we see advanced care planning related to shared decision-making. So just to use our terms, this is how we've come to use terms. Goals of care are all those big conversations that you have with people about what they're looking for, what they're hoping for, what they want, what they're worried about. in their care. You're having those all the time, right? Within that, shared decision-making is when the patient or their healthcare proxy is making a current decision, like, am I going to stop dialysis? Or am I going to switch to home dialysis? Or am I going to do a hospice enrollment? Like but they are there with you making that decision for now. Advanced care planning is when the patient with capacity talks with you and makes decisions about what should happen in the future when and if they lack capacity. And that's specifically what we mean by advanced care planning. And it's kind of helpful to remember, in fact, again, at the very beginning, our example, the patient in that example said, I'll speak for myself while I can. And it's so just reminding people that they always can speak for themselves. But if even on a temporary basis, if something happens that they can't speak for themselves, it's important to know what they would want in those situations. And that's what advanced care planning is about. So let's assume that you've talked with patients. They've come along and they're like, yeah, I'm ready to put this on paper so that my family knows, my doctors know, like, I'm ready to put this on paper. There are a couple tools that we want you to know about. So there's a website that over the years called Prepare for Your Care, which I don't know if you're using at Rogosin. Do you know if you're using the Prepare materials now?
No, I'm not familiar with that.
Okay, so
Yeah, I don't think we are, because I'm not familiar with it either.
Okay, so we want to show it to you because we think it's really a fantastic resource. So we want to show it to you. And then the Post has a patient site, which you may not know about. And the New York Post was just revised. And so Christy's going to walk you through those revisions. So here's the Prepare website over. There's the big Prepare website. Here it is. But there are two big things to know about. One is there's this whole program for patients with videos and step-by-step and stories. That it's a whole thing. And it's good. But of course, that's not for everyone. But the other part of it is just they have advanced directives for every state in several languages in most states. I think every state has Spanish. And in New York, they have English, Spanish, and Chinese. So let me show you the actual advanced directive. You can either do it as a patient and move through it. I'm not going to go through all of that, but there's that, or you can use this form. And we really like the form in terms of how forms go. And it is legal in New York. It's been researched, it's been patient tested. The language is at a low, I don't like to say low literacy, at an easy literacy level. Lots of pictures, bold and big print. It says what these parts are. So, choose a decision maker, make your healthcare choices, sign the form. What should I do with it? So it's a lot of pages, like if you print it out, but it's pretty straightforward. And it gives within the form, here's things to think about, someone you trust to follow your wishes, what will happen if I don't choose them. And it also gives in each area some things that the decision maker may need to make a choice about. It talks about dialysis. And then there's a place here if there are things that you don't want the decision maker to have access to. So that's the decision maker part. Then there's more they can fill in. How strictly do they want the decision maker to follow these instructions? Then it moves to their healthcare choices. Again, some questions about how they like to make medical decisions, what matters most, what brings your life joy. So it's bringing in some of that stuff that used to be, or is still in the 5 wishes form. What matters most in your medical care? asking people to show how important they feel living long versus quality of life and comfort is, what they would want at the end of life. So they distinguish feeling today versus end of life. Again, things they would want at the end of life. How do you balance quality and organ donation is a part of it, autopsy, funeral or burial wishes. What else do you want people to know? And then signing the form appropriate to each state in the way it must be signed or witnessed. So we highly recommend taking a look at this. We think it's the most user-friendly form for many groups and many levels of literacy that's out there. And we think it's a good idea to take a look at it. So and I know I just, blasted through it, but that's what it covers. That's what it looks like. And we've had really good feedback. It's not ours. It's been done by a different research team. I think we should get a cut of their non-existent, it's free. But highly recommend taking a look at it. The other thing we want to walk through is the new New York MOLST. So Christy, do you want to share?
Yes, I just put it in the chat box as well. I'm going to pull up the patient site here, and then I will pull up the New York MOLST. So,
and I don't know how much you guys are using MOLST and Pulse. A lot? Not so much?
Are you familiar with them? So
Yeah.
depending on your state, it may be called a POLST, provider order. It could be called a MOLST. In Missouri and Kansas, it's called a TPOP. So it just depends on the state that you're in, and the state also determines who can sign these. But these are essentially provider orders that move between organizations. So the patient can put whatever their goals are and their treatment options on these forms, and each organization will honor this form when it comes into that organization. So here's a little video that kind of talks through this. Again, is patient facing. So there's videos, next steps, etc. for the patient, and then for the providers, there's also how to talk about the POLST with your provider. This is the New York medical orders for life-sustaining treatments, or the MOLST. Can you see this okay?
Mm-hmm.
Okay. So obviously patient information here. Let's see if I can get it to move. Oops, sorry. What happened? Don't do that. There we go. Patient information is completed up here, and then they can complete, if they've completed the advanced directive, also known as the healthcare proxy or durable power of attorney, the living will, organ donation, you can mark those on here so that the healthcare providers, as they're seeing patients in their organization, can look for these documents. It's very helpful. Patients can complete whether they want resuscitation or not. And again, having that discussion of this is a resuscitative effort after the patient has no pulse and or is not breathing, and in effect they have passed away. Do we want to try to resuscitate them at that time or allow natural death? And then as you continue on, when the patient does have a pulse and is breathing, they can list whatever they want done for respiratory support, hospitalization or transfer. And then you can also make a note down here on whether the patient has medical decision making. Are we talking to the patient? Are we talking to their healthcare agent or DPOA, etc.? It's pretty extensive, but again, this was updated just last year in the state of New York. So it also tells you here that a physician, a nurse practitioner, and a PA can sign several of these areas. It does say the physician must complete an additional checklist. So just kind of follow the instructions on here on which provider can complete these. You can also get as detailed as artificially administered fluid and nutrition, antibiotics, dialysis is on here. Patient may want dialysis to treat kidney failure, determine use or limitation if kidney failure occurs, or do not use dialysis. So they can be as specific as they want in the line here. In Missouri, we have a little bit different, as I mentioned, the TPOP, but I've had patients sometimes, I'm not allowed to sign for them, but I do send those home with patients. And sometimes they get really extensive on what they want, how long they want things done. I had one gentleman that wanted to be given 21 days of, if he had to be resuscitated, he wanted to be on the ventilator, he wanted nutrition, he wanted everything for 21 days. And if after that he wasn't recovering, then he wanted all of those measures stopped. So patients can get pretty specific in this, in their details here. So this is just additional instruction and everything. And then there's opportunity up here. As I was talking, I kind of scrolled past it, opportunity to review this annually or as often, or actually this is 90 days or as often as needed for the patient.
So our suggestion was, and Jeff, this sounds like it's right up the line with what you're thinking about, is experiment with using open-ended questions. And then we want to ask that you explore, we didn't talk about My Way, but I gave you that link in the chat. Those are guides we prepared for dialysis patients and for dialysis clinicians about advanced care planning, but mainly experiment with using open-ended questions and see where it gets you. It is very different than the clinical approach of the yes/no question. And what we're going to do in the next session, and Jeff will need to talk a little bit about how we figure that out. Jillian says, okay, more knowledgeable about motivation learning. We want to talk more about the skill of empathy. So most of us can recognize empathy when we see it, but really, what is it? And Liz, do you want to give a commercial on that?
Sure. I think, what we'll spend more time talking about is what we're going to focus on what empathy is not, and really focusing on how do we articulate that we care in words and in our body language, particularly with being able to accurately identify people's emotion and name that in that process. So.
And then we're going to work on the ask, tell, ask framework, which is just different than the motivational interviewing framework, but still is using that idea of asking questions. And we've got very specific questions that apply to the dialysis and kidney failure treatment process. And I believe you guys have used those ask, tell, ask cards at Rogerson, but we'll go through that some more. And then Christy and Woody are going to present more on alternative treatment options. So how to, and again, this is specifically from not just what it is, but from the communicating about it. So how to talk about these options in a way that is balanced. We have observed often and talked about in some of our monthly seminars with you guys that the go-to language that people have inherited is sometimes pretty biased, like the language around, well, we could stop treatment. No, you're not going to stop treatment. You might be stopping this one technique, but we're still going to treat you and care for you, right? So really paying attention to that language as we offer and discuss people's alternatives. So that's going to be the focus. Great. Well, thank you. And
thank you all.
We'll see you for a case soon and another intensive session, and hopefully we can beat the drum a little, get people to give up their precious, I know it's precious time. So
we look forward to it. Thank you.
Thank you.